I am Dr. Rakesh Srivastav. Today I am going to talk about early glottic carcinoma, diagnosis and principles of management. WHO has classified early glottic cancers on the basis of histopathology into various categories like hyperplasia, keratosis, mild, moderate, severe dysplasia, and carcinoma in situ. As the degree of dysplasia increases, the chances of malignancy is higher. There are two other variants which have been added, like on the uh, on the basis of histopathology. What is microinvasive carcinoma? Other is microcarcinoma. So microinvasive carcinoma is carcinoma which is a superficial spreading with a maximum size of 10 by 10 by 3 millimeter in size, while microinvasive carcinoma that has not yet infiltrated the muscle or vocal fold, that are microinvasive type. These are the various categories which has been classified on the basis of histopathology, but on a endoscopic picture, these are the different look which you can suspect in a high definition laryngoscopic pictures. So this is squamous cell hyperplasia with mild dysplasia. So it looks like a white flat lesion on the vocal folds, which is indicative of mild dysplasia. So lesion with the exhibit keratosis and squamous cell hyperplasia with occasional nuclear ATP on histopathology. These looks like a white raised lesions with a breakage of capillaries at the periphery of the lesion. Like this one here, there is a white raised lesion there, and this is indicative of moderate dysplasia. And there is a grade 3 or the carcinoma in situ where there is a squamous cell hyperplasia and nuclear atopia in all areas of epithelium with basal cell proliferation and mitosis without going deep into the basement membrane. So workup of early laryngeal cancer is first is video stroboscopy and voice analysis. Video stroboscopy and voice analysis. So video stroboscopy, after that there is a high definition laryngoscopy, then optical image enhancement technology like narrowband imaging, then imaging by HRCT or MRI, and per-operative assessment using high definition or 4K imaging. So voice-related quality of life is assessment is very important. One has to know about the Grebas score and acoustic analysis using various types of software like Pratt, or one can use is by Pentex, K-Pentex software, in which you can analyze the quality of voice and acoustic analysis can be done. So image enhancement technology like narrowband imaging, it has recently been picked up in last 10 years, and it has definitely made the laryngoscopy, the quality of and the high definition laryngoscopy is far more better. Normally we all know that white light endoscopy comprises of 3 lights, but in NBI we use only the blue and the green light, which has got a different wavelength and which gives a different picture on using the tool with a greater precision. So this is the first classification which has come up for the early laryngeal cancers using a narrowband imaging. It clearly shows the depiction of various stages, how the cancer develops once the airway is exposed to the pollution and the changes which happens with the stage. So type 1 and the type 5 is indicated of cancer, while early lesions which are type 3 and type 4 are dysplastic lesions, and this is indicative of chronic laryngitis where there is a dilatation of the capillaries is there, and then there is a breakage of capillaries. This is like a white lesion with the underlying capillaries there. Mild dysplasia, this is moderate dysplasia, that is type 4, and now then there will be a slightly more dots are there, brownish dots, and this is like a capillary or earthworm type of feature which is clearly seen in squamous cell carcinoma. And if it is get very advanced and There's a lot of slough is there, so capillary structure it get destroyed, and very few capillary network you can see it, but more of the slough is there, and both these last two categories are squamous cell carcinoma. So the tricks of NBI is one has to use the scope more wisely, and one has to do the assessment at a very close range. So this is a trick which one has to learn using a flexible bronchoscope and examine the larynx at a very close range so that you can see the finer details. The nearer the lesion and better it will be for the assessment because it improves the pixel power of the scope. So here you can see in the periphery of the lesion there are brown dots and there are worm-like structure like this one, which is indicative of squamous cell carcinoma. Type 2 pattern indicates of oblique capillaries which is coming from the ventricular side, and these are indicative of chronic laryngitis. Type 3 pattern is umbrella-like lesions, squamous hyperplasia and mild dysplasia, in which you can see the capillary which is coming from the ventricular side, and under the white flat lesion you can see the distribution of the capillaries there. So this is indicative of mild dysplasia. This is type 4 pattern, is small dark brown dots. You can see in between there is a white lesion there on NBI, and these are mild to moderate dysplasias. Like this on the periphery of the lesion, which is indicative of small brown dots. The capillaries look like here the arborescent capillaries are there, multiple branching is there, and these capillaries they break into small dots, which is indicative of moderate dysplasia. These are the very confusing lesions like umbrella lesions, submucosal vascular pattern hidden under the hyperkeratotic surface, and in these cases one has to go with the assessment of the periphery. This lesion doesn't show any of these features, so the histopathology this matches with the moderate dysplasia or hyperkeratotic lesion. Type 4 pattern is again the same type, interpapillary capillary roots showing a high density with a speckled leg. So if you see this lesion on white light endoscopy, it doesn't show any of the characteristic, but here you can see these are the small brown dots are there, which are indicative of moderate to severe dysplasia. Type 4 pattern again, these are the earthworm type of capillary structure is there. This is indicative of squamous cell carcinoma. Type 5b with inflammatory changes. Again inflammatory changes, we have to look at the periphery. Again we can see there are changes which is indicative of this thing. Now coming to another component of it, that is tumor segmentation in mixed lesion. Lesion which has got one lesion might have a 2 or 3 pattern with it, but once we are reporting that lesion we have to report it with the highest features which fit into the knee classification. If one side shows a mild dysplasia, other side shows moderate dysplasia, the third side shows typical of type 5b pattern, then we have to report it as type 5b pattern. And separately we have to report it right or left quad separately, not like in a single go. Or site specific also we have to mention it like that. So NBI has really made the change in pre-operative assessment and per-operative also, and it has shown that it's great. This thing it has been shown in early glottic cancer. The impact of close and positive margin, the use of NBI has greatly affected the results. Coming to the image part of it, again if we see it here, this was a lesion which was there in the anterior commissure. If we see it here in this part of it, you can see there is a little bit indentation is there, which is again high resolution laryngeal MRI. Disadvantage of routine MRI is because of the motion artifacts are there, but with the introduction of dedicated radio frequency coil, the resolution is up to 1 mm, and MRI can easily differentiate between a tumor, edema and fibrosis. It detects early mucosal, submucosal recurrence, and especially helpful in cases in patient who has undergone radiotherapy. So diffusion weighted MRI, where the diffusion motion of water in tissue has to be detected, and ADC values is easily differentiate between a benign and malignant tumor, characterized by and its the water content into it, and the primary tumor, secondaries, and metastasis can be easily seen with diffusion weighted MRI. So image is must in cases of deep infiltration of vocal cords, involvement of anterior commissure, body of arytenoid, lesion extending to superior arcuate line into the ventricle or subglottic or supraglottic extension. Not in all cases, or in cases where the mid-cord lesion is there, the imaging has got its uh, is no role in mid-cord lesions. So MRI shows a sensitivity of 100%, a specificity of 97% in assessing areas like paraglottic, anterior commissure, thyroid, and arytenoid cartilage. Kuno et al. In 2013, accuracy of CT scan in image staging is 80%, and well, as compared to it, 87.5% for MRI. And integration of newer techniques like radiofrequency coil and diffusion weighted MRIs increases the specificity of MRI in such cases. CT scan has got a sensitivity of 46 to 74% with a specificity of 87 and 94%. Baker claimed higher sensitivity of MRI than CT scan, but specificity is different, 84% versus 94% with CT scan. So early stage anterior commissure carcinoma cartilage invasion rate is 8.5%, but as soon as the stage goes up to T2 stage, the anterior commissure invasion chances as 20%. Whether to do biopsy or not to do biopsy is also controversial, especially in early glottic cancer. Performing biopsy to classify grade of dysplasia is limited because of risk of misclassification. So many pathologists have got a different say on a same specimen. So official random biopsies may be insufficient because the biopsy is not taken up from a right place and underdiagnosis is there. Sometimes you have removed the whole of the tumor and it creates a confusion whether one should take up patient again for the second surgery. Following biopsy, the healing process causes inflammation and fibrosis. So this fibrosis sometimes in deeper plane, and it creates a confusion, especially if once we are doing a hydrodissection technique for early glottic cancer. Operative clinical examination, I have already pointed out, it's got a immense help, especially like this case with the supracommissural growth, and this is on the right side of the screen. This is on a white light endoscopy. It shows a irregularity, but once we move it from white light to NBI, image enhancement technology, so we can see the small brown dots are there in the right side anterior vocal fold. Using a different angle telescope, so now you can see this thing. This is indicative of moderate to severe dysplasia. Finally, the histopathology came is moderate dysplasia. So early, very early mucosal subtle changes can be detected with NBI. CT scan looks normal. So performing a narrow margin correctomy for T1 glottic carcinoma is oncologically safe, and it has got a good voice outcome, especially in type 1, type 2 and type 3 correctomy. So single stage transoral laser surgery spared the time and burden of second operation, and physician consultation, operating room and hospitalization cost is very less if the patient is taken up for a single stage transoral laser surgery. The result of transoral laser surgery depends on multiple factors like intraoperative diagnostic workup, experience of surgeon and team, post-operative follow-up, pre-operative diagnostic workup, imaging already discussed. Patient selection is very important, especially the laryngoscope, and adequate laryngeal exposure is very important. One surgeon should have a good various types of laryngoscopes to visualize difficult areas like anterior commissure. So we are focusing mostly on the early glottic cancers like dysplasias and T1, T1B and T2A. These are the early glottic cancers. So ideal goal of a transoral laser surgery is most adequate therapeutic approach, ensure highest oncological success in the range of more than 90% and lowest impact in terms of morbidity and the cost. So criteria for laser resection is mid-chord lesions, easily exposed larynx, good risk for general anesthesia, no involvement of anterior commissure, subglottic or ventricle or vocal process. Multicentricity is common with carcinoma in situ. Excision of dysplasia is advised rather than radiotherapy. So superficial spreading tumor at multiple sites, TLM, transmural surgery is better than radiotherapy. The technique that is known as hydrodissection technique using a saline epinephrine infusion, and it helps in delineating the tumor very well. It helps at the heat sink and it prevents bleeding there. And tangential dissection is easier if you use a saline epinephrine infusion there. The European Laryngologic Society has classified correctomy into various types, and the type 1 to type 5 is first classification in 2000 2001, and later on the type 6 has also been added into it, knowing the extent of disease. So extended correctomy type 5 again been divided into A, B, C, D, and anterior commissure and contralateral cord, arytenoidectomy. C type 5C is ventricular fold excision, and type D is subglottic, that is 1 centimeter below the cords. Type 6 chordectomy, when there is a supracommissural growth and something like a transglottic growth, anterior extension, anterior commissure extension or anterior commissure without cartilage invasion, that is the indication for type 6. Bilateral anterior chordectomy with commissurectomy is done. Resection of Broyles ligament and subglottic mucosa with cricothyroid membrane. If tumor is in contact with cartilage, resection may include anterior thyroid triangle, so that can also be included into type 6 chordectomy. So if exposure of anterior commissure is good, the local recurrence rate of T1, T2 can be 17% regardless of anterior commissure involvement. That is by the largest series with Steiner in 2009. So this is a diagrammatic representation of type 6 chordectomy, that is supra commissurectomy. Subepithelial chordectomy, again like this. It is used for both for diagnostic, as I told you about, single stage, and indicated for hyperplasia, dysplasia, and carcinoma in situ without microinvasion. Transmuscular chordectomy or type 3 chordectomy is indicated for small superficial cancer extending up to the muscle. Infiltration is not deep and the mobility of the cord is good. So the section of epithelium, superficial lamina propria, and vocalis muscle is done. So you can see in the diagram there is a up to that it is not through whole of the muscle mass, but the vocalis part of the vocalis is excised with the tumor itself and the ligament and the superficial lamina propria with it. So after exposing, doing the ventriculectomy, removing the false cord, we can know literally the lateral extent of the tumor and do the type 3 chordectomy like in this case. Total or complete chordectomy, that is type 4 chordectomy, is done for T1A glottic cancer. Excision from vocal process of arytenoid to the anterior commissure laterally to include the inner perichondrium of thyroid cartilage. Ventriculectomy in such cases helps in greater exposure and to have a complete chordectomy, that is type 5, without ventriculectomy is not possible. Type 5A extended chordectomy involves the anterior commissure with contralateral vocal cord is excised So dissection begins above the insertion of vocal ligament at the base of the epiglottis near the petiole and passes through the Bowles ligament. So this video and this diagrammatic representation indicates, so it's indicated for omega shaped, partially omega shaped growth, which is almost reaching up to the anterior commissure, and separation is started using a the black section, the laser section tube to separate the tumor from the inner pericardium uh, near the anterior commissure. Extended correctomy type 5B includes the part of the arytenoid like this in this. Extended correctomy type 5C includes the part of the false cord where the ventricular fold growth excision is done up to that part. And removal of whole of ventricular fold together done with part of the vocal folds. These are all cordectomies. They have a link there, and even in my YouTube channel, one can see all these various types of cordectomy on my YouTube channel. So type 5D extended cordectomy, which has included the subglottic mucosa. Then type 5-6 is tumor originating from the anterior commissure. Supracommissural growth is there, and this patient has undergone type 5-6 cordectomy. Surgical specimen were pinned on the cork or a board, and normally what I usually does is if I have suspicion of any lesion which is going into it, knowing about the one is the depth of the lesion, that is a deep margin of the excised specimen, or superficial margin where I am very close to the tumor. So that area I marked it with a normal blue ink, and then I try to save the ink by using a diluted acetic acid so that the ink stays well once the specimen goes in the formalin. The other way around people are using is a dried cucumber or a cork to fix it and use a various coloring needles to mark the anterior and the margins of the tumor. Histopathology reporting is negative when the tumor margin is more than 1 mm from the lesion, close when the distance is 0 to 1 mm, positive in presence of tumor at the surgical edge. So close is 0 to 1, and if it is more than 1, it is negative margin. So extra surgical margin taken at that and considered to be definite surgical margins. So negative margin, 6 different margin status. One is negative margin, close superficial margin, close deep margin, positive single superficial margins, positive multiple superficial margin, and positive deep margin. So disease specific or recurrence free survival were reduced in positive multiple superficial, and especially in cases with positive deep margin cases. And disease specific survival was reduced in positive multiple superficial margin, and recurrence free survival was reduced in positive single superficial, positive multiple superficial, and positive deep margin. Close and positive single superficial margin does not affect the disease specific survival. Patient can undergo second laser or can go for a radiotherapy. Deep margin positive should be considered as a single risk factor for transfer laser surgery. Early glottic cancer has an excellent local control rate. LCR for T1 region is 86 to 95% various series, and well, it is almost the same with the radiotherapy also, but there is a difference of 1% or 2% here and there. So close margin, single positive margin, monthly follow-up with high definition NBI scopy is must. Positive multiple superficial or deep margin intraoperative recording is reviewed, and the patient is go back to the multimodality, multidisciplinary discussion on tumor board, what to decide about the either the second laser or adjuvant treatment related to radiation or open partial laryngectomy. So using a NBI in the perioperative assessment helps in upstaging of the tumor. We have published our own data of early, almost 5 or 6 years back, about narrowband imaging for pre-malignant and early malignant lesions using this technique for during perioperative assessment of tumor. So single stage transvarsal surgery is lesion with high suspicions of early glottic cancer like keratosis, irregularity, infiltration with high definition laryngoscopy. Lesion has to be confined to two vocal cord with preserved vocal cord function. CT scan must in cases with deep infiltration, like what I mentioned in my previous slide, that body of arytenoid going into the ventricle, arcuate line, anterior paraglottic space, posterior paraglottic space, subglottis, or supraglottic expansion is there. Contraindication of single stage involvement of paraglottic fat, thyroid cartilage, body of arytenoid. The same with which are the contraindication for SSTLM. Why anterior commissure is different from the rest of the lesion in larynx? Because anterior commissure is a small area. It is a heterogeneous group, difficult anatomy, difficult exposure. Assessment methods are different. Staging is also different for anterior commissure cancer because of the presentation of these lesions. Advantage of laser surgery in transfemoral in early glottic cancer is which is a one session therapy, less morbidity and fewer side effects. It is cost effectiveness and safe radiotherapy for more life-threatening potential second primary and its side effect. So follow for such early glottic cancers. If the early T1A or T1B lesion is there with negative margin, it should be a two monthly follow-up for first year, and then 3 monthly follow-up second year, 4 monthly follow-up for third year, and fourth year 6 monthly follow-up, and then fifth year 1 year onwards. P2 imaging added every 6 months if it is a T2A or T2B growth. Limitation of transfemoral laser surgery, difficult laryngeal exposure and site. Anterior commissure involvement, craniocaudally, is limitation of transfemoral laser surgery. Invasion of posterior paraglottic space with adenoid fixation, again a difficult situation for transfemoral surgery. Massive infiltration of pre-glottic space, minor thyroid invasion. So on these grounds, the University of Brescia and University of Genova, they have designed a three-dimensional map of isoprognostic zone in glottic cancer by transfemoral laser surgery as a unimodal treatment strategy, and they have divided glottic area into 6 zones. So 6 zones are 6 subcategories. Stage 1 is PT1 not involving anterior commissure, T1B involving the anterior commissure, T2, PT2 that is extending superficial to supraglottic or the subglottic. So remember it, the superficial tumors are different from the deep infiltrating tumors. So sometimes we see dysplasia over the supracommissurial area above the tumor site. So this doesn't mean that the tumor has crossed over. So PT type 4 subcategory is PT2 infiltrating the vocalis muscle. So that has gone to a higher grade of subcategories. Then 5 will be PT3 involving the anterior paraglottic space. And 6 subcategories PT2 or PT3 with vertical extent across anterior commissure with or without involvement of pre-epiglottic space. So this is analysis by Pariti et al. Pariti and Piazza. Total they have taken more than 400 cases of early glottic cancers. So coming to the almost to the end, what Hurtle and given an evidence-based review of treatment option for patients with glottic cancer. It has been published in 2011. So single modality has to be there. Risk benefit analysis has to be explained to the patient. Morbidity more with multimodality treatment which outweighs the oncological benefit. T2 tumors with normal movement, tumor control equivalent and radiotherapy, external surgery or TLM. To conclude, selection of case exposure, high definition laryngoscopy, optical image enhancement technology and imaging is very important. Unimodal treatment, recurrence-free survival and local control rate and disease-specific survival is very important. All T2 tumors are not same, so official spreading tumor is different from the impaired mobility vocal cord movement. So it doesn't mean that maybe proliferative lesion which is not going deep into it, or it is a superficial spreading tumor. It cannot be labeled like a T2A without knowing the depth of the invasion of that, or is it causing fixation of the vocal cord or not. Unilateral bilateral supraglottic or infraglottic mucosal extension is non-predictive of cartilage extension in anterior commissure carcinoma, already discussed. TLM requires much experience, advanced surgical skill, proper instrumentation for complete resection of the disease. One should have a good optics, one should have all types of laryngoscope for visualizing anterior commissure, and one should be well versed with the anatomy of larynx. Thank you very much. So anterior commissure dissection will always be difficult, and this is a revision case, and third hand has been used in this case. It was a difficult exposure, but with the use of third hand, one can easily dissect it from the thyroid cartilage, and patient has been sent for further surgeries.